Ladies and gentlemen, welcome to Cardiovascular Innovations Interventional Octagon. This is a case-based new format, which is going to be competitive, and we have worked really hard to put this together along with my colleagues, Dr. Mehdi Shishehbor, Dr. Emmanuel Berlakis, and Dr. Paul Saraja. Today's topic for the first Interventional Octagon is a case-based SFA-POP and BTK cases. We have selected top 3 cases, 2 from US and 1 from outside the United States. This is a CME event, so you can claim your CMEs based on the learning objectives outlined. It is accredited CME by CME Solutions. You can get 1.0 AMA PRA credits for attending this entire conference for this hour. Let me introduce my co-panelist and co-moderator and the co-director of Cardiovascular Innovations, who has been the brainwave behind this format, Dr. Mehdi Shishehbor. He's the president of Harrington Heart and Vascular Institute at University Hospitals in Cleveland. We have an esteemed group of panelists who will also be the main judges for this case-based competition. Let me introduce Dr. John Eidt, who is the Chief of Vascular Surgery at Baylor Heart and Vascular Hospital in Dallas, Texas. Dr. Dmitriy Feldman, who is a professor of medicine at Weill Cornell College of Medicine in New York, New York. Dr. June Lee, who is the Director of Endovascular Interventions at University Hospitals in Cleveland. And Dr. Shirling Tsai, who is staff surgeon and vascular surgeon at Dallas VA Medical Center and the University of Texas Southwestern Medical Center in Dallas, Texas. Our top three case presenters today are here on the screen. They will proceed in this following order. Dr. Mohamed Junaid Ahsan, Interventional Cardiology Fellow from Baylor University Medical Center. Dr. Mohamed Alam, Interventional Cardiologist from the National Heart Institute in Menofia, Egypt. Thanks for staying awake. And Dr. Nour Tashtish, who is a Cardiology Fellow at the University Hospitals in Cleveland in Ohio. The case presentation format would be approximately 7 minutes per presenter. The total time allocated to each presenter would be 15 minutes. Interruptions by the panelists are allowed, and that time would not be discounted from the presentation timing. So that is an approximate guideline. There'll be a 5-minute break followed by announcements of results. The winner of this case competition will receive $500 of cash prize along with free ride to the Cardiovascular Innovation Symposium in Austin, Texas, which also, except for the cash award, will be also given to the other 2 participants of this Octagon. I do want to emphasize this slide regarding faculty disclosures. I am not going to read them, but they are on the screen. But I definitely want to take this opportunity to acknowledge the main sponsors of our today's event, which is CME accredited, as I said, by CME Solutions. Our sponsors are Abbott Laboratories, Boston Scientific Corporation, Cordis Corporation, and Medtronic. I do want to emphasize that without their general support, this event would not be possible, and that this event is in no way influenced by their support. At the end of this webinar, you will be able to claim your CME credit. The web link is on your screen, and also the QR code that you can scan that will allow you to get this credit and download and print the certificate. I do want to introduce you to this ongoing series of Octagons. This is the QR code and announcement for the next Interventional Octagon, and case submissions to which are now open. The topic is imaging and physiology-guided percutaneous coronary intervention. Finally, a word from us as sponsors of this event regarding our annual scientific sessions, which is Cardiovascular Innovations, the Operators Enclave 2025. This year, again, in Austin, Texas. You are welcome to submit cases and look through the entire registration portal and faculty presentations by scanning the QR code or going on to our website at www.cvinnovations.org. Without further ado, I just want to mention that CVI is committed to high-quality education, and the contents of our annual meetings, along with these webinars and other educational seminars, are all included free of charge on our website. You can either visit the website and watch these presentations, download slides, and also scan the QR code and view it at your leisure on your handheld devices. With that, Kelly, I'm going to stop my slides. I'm going to invite Dr. Mohamed Ahsan, Junaid from Baylor University Medical Center to take on and begin his first presentation.
Hey, Subhash, while we're doing that, can we just say one thing, if you agree? I think the spirit of this Octagon concept is that we put the formalities, kind of to the side and truly try to learn from these cases. So the spirit is that no hard feelings, the point is to really challenge and engage and kind of like you present at your CAT conference at home. So please, the panelists, we want to challenge, we want to ask good questions, we want to ask tough questions, and we have warned our fellows that, this is going to be the case. But again, with a good spirit of learning and making sure that, we are challenging each other rather than just patting ourselves on the back. So thank you so much.
Well said, Mehdi. Junaid, over to you, my friend.
Awesome. Good evening, everyone. Thank you so much for giving me this opportunity to present in the CVI Octagon today. Today, we are going to talk about Fem-Pop below the knee CTO. We are planning and executing a Rendezvous over here. I am Junaid. I am the Interventional Cardiology Fellow at Baylor Scott and White Heart and Vascular Hospital in Dallas, Texas. I have nothing to disclose in regards to this case. So we have a 59-year-old male. He presented to us with the right foot pain, right lower extremity non-healing cellulitis, and necrosis of his digits. His medical history includes that he is bedridden. He have left AKA 24 months ago. He's a diabetic, has CKD stage 5. He's a smoker. During this hospitalization, he had an NSTEMI and he had intervention to his RCA. And he has prior intervention to his femoral artery, right common iliac artery, external iliac artery, with an angioplasty. He had an attempted SFA intervention, but that was not successful. That's why the patient was referred to us. On exam, his right ABI is 0.20. TBI is unobtainable. On the right, we can see the picture of the right foot and the left AKA alongside. I'm going to present the peripheral angiogram now. So the peripheral angiogram, we started off from the left femoral artery. We took a 6 French access, ultrasound guided access. We took a 45 centimeter braided sheath and cross over to the right side. On the right, we can see that there is moderate disease of the profunda femoris artery, and there is a long CTO of the SFA. While we can see on the left side the reconstitution of the CTO at the level of popliteal artery, there is a lot of collaterals from the profunda femoris artery to the SFA CTO. The CTO is a calcified long CTO. On review of the angiogram, we can see as it plays that the popliteal artery is severely diffusely diseased, and the AT is occluded, and peroneal is also severely diffuse disease. On the left side, we see that the posterior tibial artery is giving the one vessel runoff to the foot. So we have, to summarize this, we have a case where the patient is presented with a CLI presentation, and the peripheral angiogram is showing a long calcified CTO of the SFA, which is reconstituting at the level of popliteal artery and has a lot of severe diffuse disease of the popliteal artery with one vessel runoff. So in this case, the clinical challenge was to limit the creation of large dissection planes. We wanted to avoid popliteal artery stent implantation, and we wanted to achieve hemodynamic improvement in the limb perfusion so that the wounds can heal. To achieve that, we decided on to have a retrograde access since the antegrade access was unsuccessful the first time. We obtained a pedal artery access with the 5 French micropuncture sheath. And geographically, at that time, pedal artery pressure was a flat line at 30 millimeter of mercury. After obtaining the access, we got the run-through coronary wire up to the distal cap. That was done so that the support catheter can be advanced up to that level. After doing that, we started with our angle guide wire manipulations to the retrograde, through the retrograde cap to the distal cap of the CTO. Then we switched to the 018 Navicross and used a Stato guide wire. First it was a Stato 20. We could not cross the distal cap. Then it was a Stato 30, and that also did not help us cross the distal cap. After that, we did multiple advancements and redirecting of the retrograde wire. And eventually we went to the 035 wire and the Advantage Glide wire to penetrate the distal cap, but we could not penetrate the distal cap, and we left our Advantage Glide wire at the distal cap, which can be seen on the left side on the angiogram. At that time, we decided that we want to escalate antegradally. So we did wire escalation, which was a targeted escalation in the sense that we switched between command and our stato wires. While the 014 system command ES wire was there, we were using the Turbo Elite laser 1.4 millimeter. And while we would create that microchannels, we will go with the stato 20 again to open up the CTO. This targeted advancement of the antegrade wire helped us cross the CTO up to the middle of the SFA CTO, but we could not cross up to the distal cap. At that time, we decided that we want to switch to the 035 system, and we used the 035 Navicross and Advantage Glide wire. And we pushed that, and at that time, we were able to meet the distal cap and the distal wire. At this time, we performed the Rendezvous technique, and we got the retrograde wire to go through our catheter into the antegrade system. We wanted to advance this catheter to limit the dissection plane, and this catheter-based approach was for the recapture of the guide wire so that we can externalize our retrograde guide wire. But as we were advancing, we can see on the left side that we had a difficult advancement. So we had to switch to the 014 system again so that we can go to the leg and then switch out to our 035 system again. Once the guide wire was externalized, we did angioplasty. We started with Caspero 2 into 80 angioplasty balloon and did the angioplasty. Then we switched to our 035 system with Jindo wire. Then we did Metacross 035 angioplasty balloon 6 into 80 millimeter at the level of Fem-Pop. After that, we dilated our mid-SFA lesion, which was calcified. But after serial dilations, we see that we were able to the SFA lesion break through. Then for the popliteal and PT, we used Nanocross Elite balloon, which was a 4035 tubular balloon, and we did angioplasty with that. After the angioplasty, we did the DCB of the Fem-Pop artery. After the angioplasty, we got the angiogram, which showed that we had a good result. We had non-flow limiting dissections of the SFA, but proximally there were more dissections. So we put a proximal SFA alluvia stent with a 6 into 100 millimeter stent. After that, we reviewed the angiogram. We had a good result. We had our SFA had limited dissections. The popliteal artery had non-flow limiting dissections. And what we can review from the angiogram over here, that popliteal artery is giving good flow. And on the right side, our PT is looking great. And we also have some flow in the peroneal. AT continues to be occluded. At the end, we had distal run flow to our feet, which was demonstrated after taking off the clamp from our distal sheath. And manually, we took off this sheath and we did manual pressure on the retrograde side. Post-intervention, the pedal artery pressure was 65 over 49 as compared to the flat line of 30. Sorry. And post-intervention, the next few days, the right foot pain improved, the erythema improved, the ABIs improved from 0.20 to 0.74. We had our TBIs, which was 0.55. We discharged the patient on rivaroxaban 2.5 milligram BID, aspirin 81 milligram daily, and clopidogrel 75 milligram daily for 1 month. So the key learning objectives of the case was that we wanted to highlight a step-by-step approach to contiguous Fem-Pop and BTK CTO lesions. We supported a guide wire selection of advancement and penetration of the distal trap, which was a crucial step. We targeted advancement of the antegrade wire with 014 and 018 system. We managed a Rendezvous zone by limiting the dissection plane and catheter-based capture to avoid recoil, which was crucial to our expeditious and reproducible case success. And crossing often dictates the definitive therapy, which in this case was limited stent implantation for the treatment of long Fem-Pop BTK CTO, which was feasible with this technique. Thank you so much.
Great job, Dr. Ahsan. That was excellent. And, maybe we can open it up to the panel to ask some questions, from the case. Dr. Eidt?
Well, it's a challenging case for sure. Nature loves symmetry. And when you have a AKA on one side or a BKA on the other side, it's hard to beat that sometimes. I think Shirling and I probably feel the same way. The durability of this is the big question mark, right?
Yep.
You have a long reconstruction. So I think it was a good job, good presentation.
Well, let's remember we are this is the Octagon, so it's not just we are not going to be nice. So basically, I think what Dr. Eidt is saying, Junaid, is that the durability of this is questionable. Why did you do it?
So we did it because we discussed with our vascular surgery colleagues and endovascular colleagues. In this case, the patient was bedridden. He was not a surgical candidate, and he had ulcers. So the other option would be like he had non-healing ulcers, so he would need a BKA or like interventions. So this was done basically to improve his CLI symptoms, so that even though the long-term durability is not very good, still, like at the end of the day, the ulcers could heal and he could have some quality of life.
Okay, great. And you felt it was minimally invasive, so not hopefully as much morbidity as doing a long bypass or some kind of a surgical intervention. Okay, Dr. Tsai?
Yes, great case. These are very difficult. I used to do these a lot with Dr. Banerjee, and it was always a fun case. And I learned all these techniques from him. So I have a couple comments and questions. One, if this patient was bedridden, like, why salvage that leg? Did he use it? Did he, he has an amputation on one side. Some of these guys, I do try to salvage the remaining leg pretty aggressively if they use it. They may use, if they can transfer or even stand on the one leg, that makes a big difference. But if he's truly bedridden, is it in someone who just had a big MI and has had all these other problems, is it really worth it to go and salvage the leg? Because even though it's all minimally invasive, it was probably a couple hours in the cath lab of just, endovascular acrobatics. One question. Second question is, did you IVUS after all of this recanalization? Because looking at your angio, you had an SFA occlusion, and then the popliteal I couldn't see, but it looked like it was diffusely diseased. So, you can struggle to get through that, and obviously you got your wires through that, but I always find that it's in that diffusely diseased popliteal where you run into problems. And having done this a couple times myself, where it looked great, you do the rendezvous, the wire's great, it looks really good on the angio, and I've had one or two of these go down like the next day. And every time I think I should have IVUSed. So now for these, I am not, you can ask Dr. Banerjee, I'm not the one to get out the IVUS all the time. But for these in particular, I try to IVUS because I feel like sometimes you can have flaps that you don't necessarily see on the angio. So did you guys think about doing completion IVUS to look for other places you might need to stent or, tack, heaven forbid, to put tacks in or things like that?
Yes, so for the answer for the second question, we did IVUS because after the rendezvous, when we wanted to send our support catheter down, we had a lot of difficulty. So once we got that, the next thing we did was we IVUSed it to see that we are not having a very big dissection plane. So we did IVUS that. At the end of the case, we did the final IVUS. So we did IVUS twice. Yes, for the first answer, so the thing was that, yes, he was bedridden for the last couple of months, but before that, he had some he was able to move, he was able to do some things. But at the end of the day, now that he had common iliac, external iliac disease with the long SFA and the popliteal disease, he was not very active in the last couple of months. He got bedridden within the course of these last couple of years, where he got this AKA, and over the span of time, he had this PAD and his heart problems that he was having. So we thought that since he got his RCA intervention and we did this intervention, we can help him heal the ulcer. Maybe he can get back to his baseline 3 months ago.
Dr. Feldman?
Yeah, no, I want to second the comments and questions that were raised, but excellent case. Also, you know, at the end, I wonder how the decision was made. Was it mostly angiography based or IVUS based regarding leaving the residual disease? As you could see, you know, the whole SFA popliteal space was quite atheromatous, calcified, and so the residual dissections. Also, the ostium of the PT, I believe, was also a bit diseased. So in terms of deciding how much to stent at the end, was that decision mostly made based on angiography, on intravascular imaging, and as the decision to leave the residual PT disease alone? How was that made?
Both angiographically and IVUS, because we did a final run of IVUS after the drug-eluting stent after the stent to the SFA, the Alluvia stent. So we did the IVUS, and then we decided that this is the result that we are happy with. So both angiographically and with IVUS. Yep.
Dmitry, I just want to add, and operator and fellow fatigue.
Yeah. And a quick question about antiplatelet, antithrombotic therapy afterwards. I know you chose dual antiplatelet and antithrombotic. Is that just because to minimize the chance of rethrombosis? Because obviously this is a very complex case, and you want to maximize at least 30-day your antiplatelet, antithrombotic therapy?
Yes, for sure. Like for 1 month, we wanted the triple therapy because he had like a stent to the RCA, and he had multiple interventions to the right side, the whole lower extremity in the last couple of days. So we wanted to maximize that for 1 month, and then we would go to Plavix rivaroxaban. Yeah.
And June, go ahead. After you, I have a quick comment. Go ahead, June.
Okay. So great case presentation. Good job. Thank you. I agree, IVUS is important. However, I think what was at the end of your case, what was interesting was that there remained about a 30 or 40 millimeter gradient between your CFA sheath and then your sheath in the PT. And oftentimes, I don't oftentimes measure this because I usually do this without a sheath in the PT. However, if I have a sheath in the PT, I notice a significant gradient like that, I would actually reach for an additional catheter and just do a pullback. So yes, IVUS may tell you anatomically where there may be dissections or calcium, but what's important to know is where's the hemodynamic spot that may be missed by just doing IVUS. And that's what may actually lead to eventually closed artery in the future.
Excellent. Yeah.
Dr. Banerjee?
I think that's an excellent point. I've seen June do OCT imaging, and I do think that there is a lot of residual gradient in this lesion. The other side of it is that I don't know if this is controversial, that even if this remains open for 3-6 months, it might be good enough to give some healing to this leg. And I think the relationship between complete patency and healing, it's still debatable. I do believe that patency is critical for healing, but sometimes I've seen that the artery is closed, but the wound has actually healed better. I've seen that discrepancy. I hope the vascular surgeons would agree. I want to add that in all the rivaroxaban usage, I think one of the most impressive endpoints for me doing endovascular is the significant reduction in the readmission with acute limb ischemia. I think was our biggest fear, that this guy will come back in 3 days after discharge or 4 days with a shutdown of his graft, and that I think would be a big setback for us. So I think that was one of the main reasons for it. The reason for putting less scaffold, I do agree with Dmitry that the ostium of the PT was our greatest concern, but we didn't have much tools. I think today we might do some other, would this be a good case for imaging and then treatment with a scaffold? I think probably yes. I don't think we had that available when this case was being performed.
Okay, great. I think, for the sake, yes, Dr.
All right, one quick question. What is your surveillance protocol?
Let me answer that question for Ahsan. I think we definitely don't do an early ultrasound. We definitely do a 6-month ultrasound. That's kind of one way we can say we standardize it. And a post-procedure ABI is my passion. I can't say it is such a great idea. Sometimes it may or may not indicate, but I love doing and rejoicing if I see a good metatarsal waveform in these patients. So those are the two things I definitely do.
Well, you'll get part of the award if he wins. You can get $100.
No, I would ask
honestly, if this stays open for 6 months, it would be a miracle.
Yeah, I completely
so
agree.
6 months surveillance to me is useless. That's just what I think. That's why this is an octagon.
Perfect.
If you don't come back and surveil this thing before then and treat the recurrent stenosis, this whole thing is going to go back down again. And then are you going to lyse him when it goes down?
I'll call you, but I think we have struggled.
Dr. Ahsan, are you going to lyse him when he comes in with a thrombosed reconstruction at 3 months?
No, I mean, we don't do that. We have vascular surgery who does that for us, but
long answer, Ahsan, long answer. Oh my God, no.
You're not getting hired at Case Western now.
You don't apply here, that's for sure.
Vascular surgeons won't come in at night or weekends, you know, they only work daytimes.
No, but I think that, you know, that this is exactly, and I'm learning that, you know, maybe we should only do 2 cases, because that's the point, to be honest with you, because we go to a lot of meetings and everybody pats themselves on the back and we are not willing to challenge each other. And to be honest with you, like one of the things that you mentioned multiple times was that this was popliteal, we didn't want to stent it. I actually vehemently disagree with that, because there is no surgeon that's going to bypass into an occlusion. If they do, the graft is not going to work. So actually, that's the best place to put a stent, but put the right stent, you know, put a stent that's not going to fracture and it's not going to cause a problem. So that should not be a reason not to put a stent in that area. Now, if you don't need a stent, don't put it. But if you need it, you need to put it. So I think that this is the beauty of having these discussions. And I'm grateful that you did the presentation. You did a great job. And we need to learn. We need to learn from each other and get different views and have these discussions in a more broader. This is the kind of discussion probably you have in your hospital, but not have it in this kind of a venue. And that's the whole point of these presentations. Okay, we should go to the next case, Subhash, because I think we are running very late here.
We'll go a few minutes over. So this is Dr. Mohamed Alam from Egypt. I think you are second.
Yeah.
Correct? Are you ready?
Yes.
Great.
Okay. Can I start?
Yes, please. Do a presentation mode and start.
Okay. Good morning, everyone. It was a great pleasure to present a case at this elegant meeting. My case today was about the disastrous beginning. I am Mohamed Alam from National Heart Institute from Egypt. There is no conflict of interest. My case was about male patient, 65 years old, heavy smoker, presented to us in a primary coronary intervention center with retrosternal typical chest pain with non-specific ECG changes and positive cardiac troponin. He was diagnosed as non-ST elevation myocardial infarction. We decided to perform an emergency coronary angiography through right femoral approach. One of our colleagues started to insert a right femoral sheath, but he feels some resistance during insertion of the J-wire sheath. So he take a look. Oops. This may be a dissection flap or maybe a subcutaneous injection. So I decided to insert a left femoral sheath and perform an immediate contralateral antegrade angiography, which revealed there was a dissection in the right external iliac artery, but actually with good distal flow. So we decided to perform coronary angiography firstly, as the patient comes with myocardial infarction. There was a mid-segment LED tight lesion, but with good distal flow. Now we have a challenge. We have a dissection in the right external iliac artery and tight lesion in the coronary artery, which gives myocardial infarction. How can we treat first? At this point, the patient developed severe agonizing right lower limb pain with acute motor loss in the right lower limb. So we perform an immediate reperform angiography, which revealed total right external iliac artery. Now we have a clinical challenge. We have an emergency total right external iliac artery, and we have no available peripheral intervention equipment. Anyone can give us solution? Okay, let's go. We decided to treat the case. We pass a coronary guide wire with a JR guiding catheter, and with an NC balloon, large NC balloon, we can restore a flow.
So you decided to proceed with the iliac intervention at this point. Is that correct?
Yeah.
Not do the coronary. This was probably
No,
not
no.
an acute STEMI, is that right?
Acute non-STEMI without
Okay,
total coronary obstruction.
Got it.
And we have now total right external iliac artery. And we restore a flow by balloon.
I'm a little confused by this. So you do not have peripheral equipment. You have a patient with myocardial infarction, albeit not a STEMI. I mean, and you are going to deal with external iliac, which is probably not a very forgiving area. What would you do if you actually caused a microperforation in that area and you have no equipment? I'm just a little bit thinking ahead. That is this the right strategy at this point? So elaborate.
Yes. Now we have a patient. We have an right external iliac artery dissection, and the patient still had ongoing right lower limb pain and section in the right external iliac artery with rapid recoil. The patient started to be severely sweaty, hypotensive, and about to be shocked. So we must find a solution quickly. But remember, we have no available peripheral equipment. So we made a rapid plan. We implant a coronary stent, Resolute Onyx 5/26. For sure, the stent was not fully opposed to the wall, so we pass a second coronary guide wire through inside it, and we perform multiple simultaneous inflations of two big NC balloons inside the stent at multiple levels with multiple pressures. And this was the final result.
Did you IVUS? Do you guys have IVUS in the lab?
Yeah. Now it was fully opposed.
No, I didn't mean the opposition part. In general, I mean, this is I won't make much comment, but if you are crossing an occlusion in the external iliac, it is not uncommon for us to IVUS to make sure before you put in a stent and expand it, because even if you are minimally subintimal, you can cause a big disaster, especially in the lack of a covered stent in your lab. So
no, the wire from inside the true lumen, firstly, and we have the rapid recoil. The patient becomes sweaty and about to be neurogenic shock.
Understood.
So we must treat it. And finally, we BCI to the LED simply with post dilatation. The patient was transferred to CCU without chest pain or lower limb pain and with intact distal pulsation, and immediate lower limb duplex revealed normal arterial flow in the right lower limb. We performed first, and 6 months later, CT angiography was done, which revealed patent well-deployed stent in the external iliac artery with normal distal flow and an atherosclerotic internal iliac artery. Our take-home message: any simple maneuver must be done carefully. Emergency interventions require careful management of the patient, but with rapid decisions. Flexibility of decisions and the plans must be present to get solutions for different situations. And thank you.
Thank you. Thank you. Great job.
Thank you so much. Okay.
Dr. Eidt.
I have a question.
Of course.
Can we bring the panel together though? You know, our IT team, can we take this slide off, please? Sorry, Dr. I just want to get us into the panel mode.
No, just a quick question. What technique do you do? What do you use to access the common femoral artery? Do you use ultrasound and do you use a micropuncture technique?
The first one, he did it radiological. And
Yeah.
the second one, I did it ultrasound guided.
Yeah. So that with the initial puncture though, you go with an 18 gauge needle and a J wire.
Yeah.
And typically you do not image the groin when you are advancing the wire, right?
Yeah.
In other words, you put a J
One
wire,
of our
you put a sheath in before you really do
one of
any-
our colleague, one
Do
of
what?
my colleagues insert the needle and insert the J wire, but he feels some resistance.
Yeah.
So he take the look, the angiography.
So how would you avoid this in the future? I congratulate you on a great bailout of a complicated problem, but really we want to know, how do you avoid this the next time? Because this is a completely avoidable problem.
Yeah.
Okay, so how do
We
you
must
avoid this
insert.
next time?
Firstly, we must insert the puncture ultrasound guided and with micropuncture. In no advancement of any wire with resistance, no advancement of sheath without the wire become in the aorta.
But
I mean, I think those are good points. Personally, I'd try to emphasize even with a micropuncture technique to fluoroscope the micropuncture wire. And if the micropuncture wire is not forms a J, you will never get a dissection. That micropuncture wire is too soft to ever cause any harm as long as it's pointing toward the heart. Once you have a J, it's a harpoon and it can create a dissection. Second question,
It is not.
what would you do?
It is not available
if
in
you
Egypt.
had-
The micropuncture is not available in Egypt.
Yeah.
Got it. Quick question. What would you do if after you put your stent in, that's an uncovered stent, correct? Your coronary stent?
Yeah.
What do you do if you perforate, if you have extravasation from your external iliac? What would you do?
We can perform a balloon tamponade with two big balloons.
Yeah. I mean, I congratulate you, given the situation that you were in, but you know, unfortunately, two balloons that are laying side by side won't necessarily tamponade as a single sausage would. You know, you don't really have an ability to tamponade. So I'm glad you got out of it. The other thing I would say is that an external iliac occlusion is not a life-threatening or limb-threatening problem, right? You have an internal iliac that's patent. You had good collaterals to a big common femoral and a good profunda and an SFA. So while the guy had pain, I guess my question would be, why do you think he had so much pain that forced you to treat the external iliac occlusion rather than moving on and treating the coronary initially?
I think acute occlusion can perform this severe pain.
I am not convinced. I am not completely convinced. I urge Mehdi, June, Shirling, and Dmitriy to opine that initial blind pouch that I saw on retrograde injection, is that the external iliac lesion? I am not at all convinced. I think what happened was that you injected from the needle, you saw a common femoral dissection that entered just above the inguinal ligament. When you came back from the other side, you actually are seeing a lesion that is not caused by the axis itself. And that has actually opened up in the antegrade direction. So I think you treated a good lesion, but I'm not convinced you treated the dissection you caused at the axis site. That's my interpretation.
No.
That's why I was asking.
There was a there was a dissection appeared in the antegrade angiography. If you
And
want,
typically,
I can share it.
I think Subhash's point is that, I mean, we've all seen these retrograde dissections. Oftentimes you take out the sheath and the antegrade flow is actually sufficient to seal that area and provide antegrade flow. So it's kind of surprising for the patient to really truly be asymptomatic. I am actually, ironically, the vascular surgeon on the panel mentioned, could this have been a coronary issue causing the hypotension? I actually agree that maybe it was actually the coronary. You just don't see hypotension from acute limb. It's just a little bit odd.
You know, when you mentioned his symptoms, I would have sworn the whole thing was thrombosed. Because when you hear that he had excruciating pain and he had loss of motor function, my first thought was you're going to tell us that the external iliac and everything past it had thrombosed. And then my question was, well, what would you do with that? You know, because I have seen this exact same problem where you get an access site problem and you have to have a dissection. And then the next thing you know, the whole external iliac and common femoral is thrombosed. And it's not just a matter of fixing the dissection, but you also have to do the thrombectomy. So I guess my question is, one, how would you manage that without peripheral equipment? And two, do you think based on this case, you will have peripheral equipment in the future? Because with all your coronary interventions, you're undoubtedly going to have difficult access patients too.
Firstly, we have no thrombosis. We just have a dissection, and the anti-grade flow after dissection was good. And when we passing a wire, we take an angiography up to down to the PTL artery. We have no thrombosis. And we cover the dissection by the stent and fully uphold it.
Dmitry, any thoughts? If you have a groin complication in an ACS patient, which one should we treat first? I mean, I know this is a fundamental question. It's not an easy one to answer.
I mean, I think, as was mentioned, you know, this is a little bit of an unusual presentation, and I agree with what was said. You know, it's a little hard to put together the angiogram that we saw from the femoral and the up and over angiogram. And I think, you know, it is very possible that the iliac lesion was somewhat unrelated and not necessarily the culprit. The other thing I would say is, you know, good angiography, subtraction angiography with oblique views will guide you. And here, I think, you know, just taking a few pictures may also not be an ideal angiography to make the diagnosis. And the third point or question, you know, considering that you're in a tough spot and you don't have a lot of equipment, as you've done a balloon angioplasty with a very small coronary balloon, if you want to do a better job with angioplasty and kind of deal with the recoil, then you could have taken the long kissing balloons and put them at the site of recoil and left it for a longer period of time. I think, you know, prior to putting a small stent, I would probably lean towards that strategy first.
Dr. Alam, you have definitely intrigued us. This is a great case presentation. And I tell you, my lesson for you and my friend is that you need to be involved in peripheral intervention, and your lab should have some peripheral equipment. And I think this is extraordinary. In the situation you found yourself, you have bailed yourself out with great confidence and great vigor. Congratulations. So thank you very much for joining in at such an odd hour. We appreciate your enthusiasm and look forward to seeing yourself and many of your colleagues at CVI.
Well done.
Thank you so much.
I hope you are now more invigorated than you were at the beginning of this presentation of this case Octagon. So over to you. Share your screen, and we are excited to hear from you.
Absolutely. Thank you. Thank you. Okay, 1 second here. Share my screen.
Now it's good.
Good. Okay. Okay. Good evening, everybody. Thank you so much for being here and such a wonderful evening to spend time with you. Hear your opinion, presenting our challenging cases. And without further ado, my name is Nour Tashtish. I'm an interventional fellow, endovascular fellow at University Hospital Cleveland Medical Center. I don't have anything to disclose for tonight. The patient I'm going to be presenting, it has been a challenging case that we took care in our institution. She's a 73-year-old female. She is coming with a left lower extremity pain and a non-healing wound. She has a past medical history, extensive peripheral artery disease. She has multiple revascularization. She has hypertension, diabetes, COPD, Crohn. I'm going to go over her PAD in a little bit more depth shortly. Pertinent lab, she has a lipo-A of 62. and she has an LDL that is actively being treated, and she has a goal that was reached of 34. This is basically a timeline of her peripheral intervention. Of course, we're talking about the one limb of interest. Back 2 years ago, had a DCB, and actually 3 years ago, DCB and Supera in her Fem-Pop. And then a couple months later, she came in and she underwent an endarterectomy. It was a bovine patch. That patch got infected and the groin show. She went through an extensive IND, and she had a flap. And then that stent that was placed in 2022 got occluded again, and she underwent a DCB with a laser atherectomy back then. And then after a couple of months, the patient will come again with severe decreased perfusion, and subsequently an angiogram. Her stent again occluded. She underwent a DCB, and she had a stent to secure the outflow of the stent, this time stenting the AT and PT. At this point, the patient again presented with same presentation, severe breast pain. And at that point, the patient was referred to our colleague vascular surgery, who performed a bypass from the profunda to the DP, a long bypass cryovein, a cadaver vein. And the presentation where we were involved, we don't have a time to go over all these in details, but basically we got involved at that point after her graft at this point got shut down. So the patient, she stopped feeling pulse in that superficial graft that was placed. And at this point, the surgeon re-involved our endovascular team, and there is a meeting that was held within our institution. It's called LSAC, Limb Salvage Advisory Council, where we get everybody on board, our colleague, the surgeon, and endovascular, and we go over the options for the patient, trying to preserve the limb as much as possible. So the decision was to take the patient again to the lab and see if we can do anything further for the patient. And as expected, again, the failure is the stent. So we have here a Supera that was placed in 2022. This case was December 2024. Multiple DCB. No stent was placed into the Supera, so 2 times laser, 2 times DCB. And as you see here, there is a reconstitution at the TP trunk level. So
Dr. Tashtish, can I ask you a quick question? What's the indication for this procedure right now? What are the indication for doing this right now?
Okay, Dr. Shishehbor, thank you. So the patients came again with the rest pain, and the graft that was placed with the vascular surgeon, it went down basically, and she had the wound of the bypass, which is, I took the picture up because I don't want to focus that the presentation was mostly wound, but she had the wound of the bypass graft that was non-healing, and there was delay in healing also. So basically, rest pain, non-healing wound of the bypass graft, and the bypass itself, there is no pulse anymore.
Makes sense.
So as you see here, the approach basically going in, we have a microcatheter. We tried the first with the SAG, and we were able to make some progress as the stent, but then eventually the SAG, the stiff angled wire, keep going behind the stent struts. And at this point, we decided to obtain a retrograde access and trying to go retrograde and make our way up. We obtained an AT access, and this is just to show you the retrograde access, confirming that we are in the AT. And eventually, we were able to cross. I didn't put all the images just for the interest of the time, but just to show you here that we made externalizing the wire. And we basically placed a filter, trying to, as we're going and cleaning that stent, not to try our best not to trash the tibials and then make things worse than it is. Here, I'm just going to stop and just go over this real quick. Here we have a stent that failed a couple times, failed the DCB, failed the laser atherectomy. So basically, the cornerstone that I want to emphasize here in this case, and in all cases that should be, is basically imaging. As everybody mentioned in the previous cases, the always question is, did we image or not? So this very important part of this procedure is imaging and trying to identify the failure of the stent. This is the following, it's a very nice chart here I found. So we have a lot of factors, anatomical factors. Could the stent be undersized? This is a question. A lot of times, stent was placed somewhere else, and we don't have the records. And we don't know the size, we don't know the vessel size in and out. The other thing is the patient itself factor. So we know the patient has a CKD, patient has diabetes, female, and she has obesity also. And then, as I mentioned, also the anatomical factors. She's a female. She probably has small vessel, severely calcified. And we have here lesions in the mid SFA all the way down to the POP. And we have a very important aspect also, the inflow and the outflow of the stent if we have a disease below. And so as you see here, after we made our way and we crossed the stent occlusion, we went ahead, and I didn't mention this, we did basically laser atherectomy, we did a jet eye mechanical thrombectomy. After we thought that we cleaned a little bit of the tissue inside the stent, we went ahead and we did an IVUS. And as you see here, as I'm training and I'm learning also from my attendings and all the people I'm working with, I expected the neointimal hyperplasia, the laser, and then the thrombectomy is going to be helpful. And then surprisingly, I see all this inside the stent, which is here. We stop, we take a pause, and we thought, is enough what we did so far? Is the DCB enough at this point, or should we do something else? With maybe a little bit the stent undersized compared to the vessel of 6 millimeter, the stent was placed 5.5. Maybe this is one factor, but the other factor also, as I mentioned, based on the imaging, is the severe calcium neoatherosclerosis with severe calcification. And as you see here, the stent, I'm here, and then the calcium is inside the stent. So next step, we decided to do something different. We have a patient that failed a couple times, and it doesn't make sense if we go and we just do the same thing that we did before. So we went ahead and we used IVL, intravascular lithotripsy. So we used a 5.5 based on the vessel size. We delivered 120 shocks, and we were able to make some progress, and we had a balloon of 5.0, 5.50, and DCB6 afterward had a nice expansion. Just to show you here, we have the filter, so you don't see a great flow down the AT. We removed the filter because the filter has a lot of probably clot from the atherectomy, and after we removed it, we got a nice flow. Now the question comes, what should we do here? The decision eventually, we can discuss this with the panelists if you guys decide to ask me this question. We went ahead and we placed a Viabond inside the supera. And the goal basically to secure that stent and maybe trying to exclude what's thrombotic in the stent, making it to thrombose every time. So we placed the 2 Viabond stent, cover stent. And the question here, we can discuss this if we have time. You see here a little dissection. So our stent stayed here. We were trying not to cover those branches just in case. And we thought this little dissection may not be flow limiting. So we decided to finish our Viabond here and trying to keep that collaterals, those branches, viable in this case. And as you see here, we got a nice flow down all the way to the front. Giving a tenuous limb situation here, 2 weeks and 4 weeks follow-up. Unfortunately, the patient came in again with rest pain, similar to the previous presentation, and we ordered an ultrasound, and the stent is occluded again. The patient was already sent on aspirin, Plavix, Xarelto as much as possible, and unfortunately, the stent again closed. And this is the TBI we obtained here, as you see on the left. We have a flat wave in the TBI. The PVR waveforms all looks flat. We went ahead again, since we did the investment on the last procedure, and in our mind, probably the place of the occlusion was that place, or the thrombosis place was the same place that we left out, or maybe the AT if we didn't secure enough back the outflow. And as you see here, the stent again closed. So we did the same. Fortunately, we were able to cross-integrate without a lot of details, wires and microcatheter, but we were able to make our way through. We did mechanical thrombectomy as well. And then after we decided to use a different modality just to try to see what is the underlying mechanism of thrombosis this time, because you're talking about 4 weeks now. And as you see here, the OCT, I took still pictures from the beginning. So there is not much of a thrombus here. As you see the stent, we see again a lot of calcium, and this is the place where we left behind the first time. And it was inside the supera to begin with. That's where we want to preserve the branches. So at this point, we decided probably we should go ahead and secure that inflow here. And as you see here, this is our previous stent, the calcium, and we have now 2-layer stent. And I just put the IVUS picture next to the OCT just to show you the beauty that both of the imaging modalities are perfect and give you a really nice idea of what's going on. You see here our stent, and then you see the endograft here, and you see the calcium that's trapped between both of them.
Can you clarify, that's where the Vibon is?
Which picture? So this is, we started our OCT here. This is
I'm gonna interrupt. So inside of Vibon was actually clot. So here at around 10, 15, here you can see that's all clot. That's all red clot. And then just above where the, go back to about 22 or so. So just above where the Vibon is, we were again trying to avoid jailing that collateral with the Vibon. Just where the collateral goes off at about right here, 12 o'clock. And then above that, actually, you see some neoatherosclerosis. So really the OCT was significantly different quality-wise. You can actually see little jagged edges of calcium if you keep scrolling to probably about 25, 28 or so. You can start seeing some calcium come up a little bit at around 9, 8 o'clock on this. You see that right here? So truly, this is neoatherosclerosis. So essentially, stent failure can be two mechanisms, which is protein deposits with proteoglycans, like in the coronaries, or neoatherosclerosis. So in fact, given this image, I was pretty convinced that we probably should have just treated this area with the prior intervention. The other part that I honestly was concerned about was the more mid SFA, so at about kind of 60 or so would be kind of where that run is. So outside of the initial stent from 3 years ago. But given this, we thought that neoatherosclerosis was likely the driving factor.
Thank you, Dr. Lee.
Okay, you have 10 seconds.
Yeah.
10 seconds. You gotta
Oh,
finish.
sorry. Yes, yeah. There you go. So as Dr. Lee mentioned, so we treated that little segment that we left behind inside the old Supera, and we secured also the outflow. As you see here, the 80, we felt a little bit may deserve just kind of secure outflow for the stent. And as you see here, we added 2 procedures in this patient timeline. And at the end of these slides, I just want to emphasize about the importance of the intravascular imaging. It gives us a lot of information as far as stent sizing, the failure mechanism, as you said. And both inflow and outflow is very important factor also. Despite of what we do for the stent, we should always think about securing the inflow and the outflow. Identify and address the underlying cause. So this is, as I mentioned at the beginning of my slides, about the lipo-A. So this patient, interestingly, after we finished the case, I went back and I looked up. I expected her LDL is going to be 100, 120, but apparently her LDL was 34, but the lipo-A was the 50, actually 65. And then I went back and I did some research and literature review, and apparently this has been a really great area of interest. So there is a nice paper from Mayo that they looked at the lipo-A for the stent in restenosis, and there is a significant, turned to be lipo-A, it's a significant independent factor for in-stent restenosis. I don't want to go a lot into this, but just to bring your attention, those one of the patient factors. So we placed the patient on Xarelto and Plavix, and we intensified her LDL and lipo-A treatment, trying to avoid this. Thank you.
Great job. Thank you very much. Maybe we can take off the slides if you don't mind. Stop sharing so we can see the panel, and we're gonna start with Dr. Tsai. Any comments? Any questions? What are your thoughts about this situation?
I think it's a great case. I think it's actually very hard. And, the hard part of this is that it's ischemic rest pain. So, you've sort of exhausted a lot of interventional things already, the Supera and the popliteal, you don't want to go back into the groin after a femoral endarterectomy sartorius flap. So they did a profunda to tibial bypass with cryovein. I feel like at that point, you're kind of exhausting your options. And usually when I see a patient like this who's failed endo repeatedly and failed a bypass, at some point you need to tell them we're running out of options, and especially if it's ischemic rest pain, because for a wound, you can say we can do something. And as long as whatever, intervention you're going to do is open for, a couple months so that the wound heals, then there's something there. But, for ischemic rest pain, even a cryovein bypass, that is not a very durable thing. And so then you're kind of, once it goes down, you're in the same boat again. I think this was very heroic. You've already gone back and tried to thrombectomize your popliteal viabon. Like, what are you going to say? My question to you is, what are you going to tell her when she comes back? Because she'll come back, invariably. She'll come back probably in a month, maybe 2 if you're lucky, with ischemic rest pain again. And then, what are you going to tell her then?
That's right. And Nour, any thoughts about, at what point, have you thought about at what point is enough, and, we shouldn't keep doing these procedures?
Yeah, Dr. Shishehbor. I mean, as Dr. Tsai mentioned, that I started also putting the timeline just to give the audience where we are here at this point. There is several procedures, and as you mentioned, this cryovein, and that procedure, when we took her the last time, was based on the LSAC meeting. That's where we have the surgeon and we have all the endovascular. So I don't know, next time she's going to come, probably we're going to meet again with the vascular surgeon, with the endovascular, and we just have to, see again our options, Dr. Shishehbor.
Could you clarify, when you did your retrograde puncture in your AT, you were proximal to the DP anastomosis from the vein, from the cryovein, right? And I noticed I'm not saying you intentionally didn't show the foot, but you didn't show the foot on your arteriograms. And if that anastomosis in a vein graft that's gone down at a DP, the chance of any flow getting into the foot, in my experience, would be close to 0. You're living off of some kind of little micro collaterals down in the foot. So what did the foot look like on your final arteriogram? In other words, it's hard to get past where that anastomosis is, where it's thrombosed. You follow me on the DP?
Right. No, that's correct. Actually, I don't think it looked bad, Dr. Lee. If you remember, I don't think it looked bad, the foot. We were able.
It actually didn't look bad. She had a little bit of spasm at our access point. And you can see on the angiogram where we accessed the distal AT, there was some flow into the outside of the artery as well. But that was one of our concerns on the initial procedure. We actually, because of the spasm, the bleeding, we actually did go down and give her vasodilators. And actually the dorsalis pedis was patent. And to the area of the bypass graft, there was a wound there, still a very small wound from the bypass graft itself. But we wanted to ensure there was outflow, as you're alluding to ensure there's patency.
Yeah.
I want to maybe ask if I can comment 3 points. First, you made me very happy by including lipoprotein A under critical pertinent lab. Number 1. Number 2 is that there is one quintessential difference between coronary imaging, which interventionalists like myself, June, Mehdi, and Dmitriy are very strong proponents, is that in the coronary imaging, you optimize the stent and you find it mostly the way you left it, because there is no effect of external compression, which is not true for lower extremity stents. I have done a lot of IVUS in my life. I have made those look good. And when I came back 9 months later, those stents look completely distorted, whether it is the torsions of the SFA, Hunter's canal, or it is the compartment. It is not exactly proven that optimization of stent with imaging in the lower extremity renders those stent exactly the same way as you left it. So I think this is work and food for us to think. What do you think? I agree, OCT provides greater insight about thrombus, but how do you account for this external compression and distortion, or the mechanical distortion of these stents in the lower extremities in the future? And why don't you think is that contributing to the failure of our endovascular intervention as much as optimizing from the intraluminal side of imaging? I know it's a hard question, Nour, but take a stab at it. You are the next generation. When my leg goes down, I want you to know this answer.
No, I mean, I agree, Dr. Banerjee. This is a very valid question that I'm thinking about it the first time as you're talking. And I'm trying to see, is this question to me or Dr. Shishehbor? So, yeah, but yeah, thanks. I mean, you're bringing a very, very valid point. We're talking, I mean, I know we use Supera, right, in the place that where we believe there is an external, but as you said, I mean, I do a lot of cases where we see sister lesions, right? You see the SFA, we fix it, and then the other one. And that's the point that the external factors, same location, and then in the SFA, probably that's where the patient use and sit and stand. And I was asking this question, Dr. Lee, one time. So I agree with you. I mean, I don't know, maybe just use all this Supera everywhere should be. I know it's just for the POP area where we think that's the mechanical, but we're seeing those sister lesion, and I agree with you. Yeah, I mean, that's a very valid. That's what I have.
We tell these patients not to do certain things. So we had a patient where we put a Supera in a Viabond for a popliteal aneurysm, and we told him do not squat. We just told him, like, he was a gardener, so he liked to be outside sitting in his garden, and we just told him he couldn't squat in his garden anymore. And I can't remember if the stent stayed open or not, but you have to wonder if, like, sometimes certain positions sort of cause, because the knee is not a natural place to be placing these stents, even if it's a Supera or a Viabond.
Dr. Feldman, anything from you? Give Nour a little bit of tough questions, Dr. Feldman. He deserves it. What do you have?
Well, I think, this is as tough of a case as they come. And I think, several points were made. I think imaging is great. But to Subhash's point, in the periphery, I mean, number one, we have to know what we're looking at. Just doing the imaging is clearly not the answer. And it's hard to interpret the imaging in the lower extremities, given the external factors, given the complexity of the external forces on the stent. So, it gets to the point of that the imaging can guide you and make sort of very thoughtful decisions, but it doesn't always give you the answers, nor do we know the answers that have been sort of clearly shown in trials or at least small studies. I do think, initially when you try to optimize the stent with lithotripsy, that was, a very thoughtful decision. I would say, the larger you can make that vessel and expand the calcium outside of the stent, the better it is. I think, taking a larger diameter, perhaps of a lithotripsy balloon may have been helpful, but sometimes, unfortunately, once the stent is in and external calcium and forces, there's only so much you'll be able to expand it. And as was said before, even if you do expand it, those forces will continue to work. So I guess my tough question at the end, what is the number one, surveillance for this patient? Number two, how much are you going to optimize this patient now from medical, a pharmacological standpoint? And number three, what is the next step when the patient comes back?
Yeah, thank you, Dr. Feldman. Very, very important question. So I guess that, I mean, when the first time we did the procedure, we scheduled the patient to come back within 2 weeks with testing, which is one part of our protocol. But this patient, probably we need a little bit to watch her closer and watch her compliant with the medication also. Another very important thing, I think the patient at some point was not taking was taking her Xarelto with food or without food, I don't remember. So we switched her to Eliquis, and then we referred her to our cinema clinic, which is a comprehensive LDL lipo-A kind of assessment. A lot of times we do those procedures, and then when her graft or her stent goes down, this is probably too late, but maybe we should think also differently. So we switch her to Eliquis, trying to maybe, the Xarelto she's taking it, and then the Eliquis, and then we refer her to the cinema clinic, and we put her on the PCSK9. But to your question also, I don't know, like probably we should bring those patients more often than other patients. whether we do testing every time or go by symptoms. As far as I know, this patient every time comes with a rest pain. And then there is the interval between each of other procedure is 6 months. So maybe you should bring those patients more frequently and watch them closer and make sure they're compliant with their medication. I don't know, that's what I have in my mind.
I think, Dmitriy, you raised a good point, and then specifically in this patient, there was perhaps some questions of should we have just anticoagulated her upfront, kind of full on. You know, we played around with some Xarelto 2.5, you know, a year ago, et cetera, et cetera. But certainly maximizing what you have in your armamentarium for medication wise. I started her on PCSK9 to help with the lipoprotein component. She's on full dose NOAC as well as P2Y12. And I think it's important, and we talked about this a little bit on the first case regarding surveillance, right? So the patients that have wounds and sores, they really should come back to your clinic pretty frequently, especially in the first heydays of post-intervention. Depending on how big the wound is or how concerned I am about their progression, I usually have them follow up at least at 1 and then 3 months initially. If the wound is getting better, then we space out to 6 months for the next one. So it's 1, 3, and 6. If I'm really concerned about a wound, for example, a heel wound or a very tumultuous TMA, then I would bring them back sooner. And I think it's important to recognize that you do need surveillance imaging for these patients.
Thank you, Nour. You know, I know that the judges are working with Subhash to score, you know, the winner, so we can announce it. So while that's happening, let me once again thank our presenters. It's only because of you that we can learn and challenge, and we want to have cases that we have something to say. If you show a very straightforward case, obviously, then it will make it, you know, it will make it difficult. There is an attendee case poll too, so where you can also vote, the folks that are in attendance. So please vote. This just came up on your screen. This is a poll, and the panelists and Dr. Banerjee will take the scores and your vote also into consideration. I think the one thing that I get, if I may say this with permission from the panelists and Dr. Banerjee, I think the one thing that at least I'm going to take home from this tonight is that sometimes we may have to say no. And sometimes we may have to take a step back, you know, so that's definitely something to take into consideration because, you know, and, you know, it's regardless of whether it's surgical or endovascular, it's like quicksand, you know, once you commit, it's like you can't say no. Now you're going to do another one, then we're going to do another one, then you're going to do a bypass, then you're going to come do lysis, like Dr. Eidt was saying earlier, then you're going to do another one. So, you know, at some point we have to recognize that, you know, the idea of doing repeat procedures is, it takes a burden. It also honestly puts us in a bad predicament from a standpoint of being able to offer this to all patients because the cost of care goes up significantly and we have those issues to deal with. The second thing I think I got from this presentation tonight, which I'm going to take home, is that if you're going to do something, do it right the first time, because if you put a stent in these calcified arteries that are underexpanded, man, you make it hard for the future teams and for the patient, obviously. So not doing the right thing the first time does have implications for us down the road. I don't know if those are the two take-homes for me. I don't know, maybe we can go quickly, and if each of you, the panelists, can, and Dr. Banerjee can share maybe 1 or 2 things also, that'd be great for our audience and for everyone as a kind of a take-home message. Maybe I start with Dr. Feldman. Any take-home message, Dmitry, from your standpoint?
Yeah, no, I think number one, I would say, of course, technicalities are important. So technical skills, like in the first case, it was very wonderfully shown that, you know, very complex number of catheters and wires, you know, you need to develop these skills, don't come, you know, immediately. This is all practice. So skills are important. You have to, you know, perfect your skills over time. Number two, as was shown in the second case with the complication, you know, you have to know how to deal with complication, and your lab needs to be prepared. You need to have the right equipment. You need to have not just yourself, but the staff know how to deal with complications. So always be ready. And number three, I think from the last case, I do think imaging is very important, but we need to figure out and have more studies and trials to how to use imaging to really help our patients.
That's great. Thank you. Dr. Lee, any teaching point, at least one or two?
I only have one, which is endovascular is so much fun. I mean, look at all of these cases we saw today. The ingenuity with the second case using only a coronary stent and then parallel balloons. I think everyone should do endovascular.
Thank you. Thank you very much. Great advice. Dr. Eidt?
Yes, I loved the presentations and I loved the enthusiasm. And I think if you ask Dr. Nour, for instance, when do you stop? As a fellow, you never stop. So you just, if it comes in next month, just do it again. Because I do think there's some value, particularly in a training situation. As you said, these are catheter and wire skills that you can't synthesize. You can only learn these by doing them. And look, we all know these, especially the first and the third case, these are challenging cases. We know the durability is not going to be very good. We know that we're trying to get very short-term benefit. But if you don't know how to do these things technically, then in situations where you likely have long-term benefit, you won't have the skill set. So I do think it's important to continue to push. I love OCT. I know I've seen Dr. Lee present those before. I think it's really valuable imaging. By the time you take a Supera stent and then put Viabon inside, it's almost impossible to get those to expand. You wind up with a lot of junk in a small space. And, the body wants flow, and it's hard. A coronary is a little short vessel. When you start taking long pieces of spaghetti and trying to run a lot of flow over a long period of time, it's just hard to deliver that through very stenotic long channels. I mean, it's the length and radius, what these equations look like. It's hard to achieve a lot of flow in the foot. I thought it was great cases. I really appreciated the presentations, particularly our friend from 3 a.m. in Egypt. I'm amazed he's even awake to take a beating. And it was a very interesting case.
Thank you so much.
Thank you so much.
Yes, I love these case conferences because I always learn something new from every one of them. And it's actually just fascinating to me to get different perspectives. So I think the thing to take away from this, in addition, is just to every case, you can learn something from it. Whether it's a complication or if it's a successful case, there's always something new to take away from it.
Thank you so much. I'm going to hand it to my co-moderator, Dr. Banerjee, for final important comments.
Yes.
And also the winner. Thank you so much.
Yes, I want to first start off by saying that on Thursdays after 8 p.m., you get the most benevolent version of Dr. Eidt. On Thursdays and Tuesdays at 7 a.m. or 6:45, you do not see that, but I'm so grateful to have this version of you this evening. But I think this was a fantastic case for me. The take home is that each participant was able to clearly under pressure rationalize the judgment behind their actions. And I think it is not the success of the case, but the rationale with which you act makes you a better operator, even if that particular case is not successful. And I think that as a fellow, as an operator, is quintessential. So without further ado, the most important announcement, by one single point, I think Dr. Nour Tashtish has actually won today. This is a combination of faculty voting, excluding Dr. Shishehbor and myself, and a proportion of the votes from the audience. We had a huge audience today, by the way. We reached close to 60 people, I believe, at the peak of our presentation. And 67% of those cases were voted for Nour. So nothing to be disappointed about. I think this is how it is. Nour, are you married?
Yes, Dr. Banerjee, I'm married.
Good. This is extremely helpful. And I hope to see you with full family at the CVI. Now, Junaid is married also, and Dr. Alam, you are coming to CVI with family and make it a family vacation. I invite you.
Yes.
I think we're going to make sure that we are going to provide you with accommodation and travel grants to make sure that you are able to attend CVI and enjoy it. And I do want to thank Dmitry, June, Dr. Tsai, Shirling, and Dr. Eidt for making this evening as focused and as fun, enjoyable, and is such a tremendous learning opportunity. I hope Cardiovascular Innovations is living up to its reputation of being the operator's enclave. Mehdi, final word to you before we say goodbye for tonight.
No, man, you got the final word. Beautiful. Thank you again. And again, as I said, it's all about learning. And, I'm so glad that our panelists did justice, and, we really challenge each other and learn from each other. So thank you so much. And I hope you tell all your friends that we have a new way of doing education now. And we're going to do it via live conferences like this with cases. Thank you so much. Have a wonderful evening. Thank you.
Thank you. The check is in the mail, guys, and the CVI invites and travel grants are going to be in your emails. Thank you again for making this such a fantastic evening. Bye-bye.
Thank you so much. Thank you.
Thank you so much.
Thank you so much, all. Nice to meet you.